On this episode of the Ask Mike Reinold Show, we talk about an internal brace augmentation to MCL repairs of the knee.
The Ask Mike Reinold Show. Helping people feel better, move better, and perform better.
Before we get to the podcast, I wanted to make sure you knew about my free online course on the introduction to performance therapy and training. If you want to learn how to get started optimizing and enhancing performance, this is the course for you. Head to mikereinold.com/performance to sign up today. Welcome back, everybody, to the latest episode of the Ask Mike Reinold Show. We are here, Champion PT and Performance up in Boston, answering your questions. Anything you want to talk about, physical therapy, sports performance, career advice, we're here for you. Just head to mikereinold.com, click on that podcast link, and you can fill out the form to ask us questions. Let's see. We are here today with, I'm gonna mix up the order a little bit. I'm gonna zigzag through my Zoom screen. We're gonna go Dan Pope, Anthony Vedetto, Dave Tilley, Lisa Lowe, Kevin Coughlin, and Lenny Macrina here for your questioning pleasure. Right, Len. Who do we have for students here? We got a good crew. I mean, I don't know. This is a solid one.
We have a really good crew. I really have taken a liking to this crew. Yeah. All right, we have. Well, I guess Ben is in the foreground. You know, if you're watching, which you're probably not. Ben Fugit from Creighton University. We love Creighton University because of Terry Grindstaff and his connections to the program. We have Brooke Young from University of Rhode Island. Brooke is an amazing student that we love. Kyle First, not second, Kyle First from Gannon University. No idea where Gannon is, but I think it's in Pennsylvania, right? Pennsylvania. And then Garen Schweigart from the University of Utah. Go Utes. I think I nailed that.
I said I love that you think you nailed that, which is great because like the only thing I was thinking, I don't want to get political here, but like that felt like a Trump press conference.
I felt the exact same thing.
Right?
Wonderful, great, just good, great. We love her.
Brooke is beautiful. Everybody's beautiful.
Start doing like
amazing. Yeah. That's all right.
Hilarious.
So we're not going to get into that.
We don't want to get that. We don't want to.
Anyway, all right, sorry, but we're not. There's no political favoring, and there's nothing behind that. It was just more, yeah. Anyway, all right. I'm nervous. I got nervous. All right, students, ask a question.
All right, we got a question from Brenna from North Carolina who says, I just adopted a patient from a different therapist who had an internal brace for his MCL in his knee. He's 3 months out and still struggling with flexion and extension range of motion and also very poor quad. Any experience on internal brace in the knee and wisdom on how I can help with him?
Awesome. All right. Great question, Ben. Brenna, thanks. Good question for Brenna. I wanted to share this with everybody here. I think it's a debatable topic or conversation at least here. So internal bracing, right? So this new augmentation of repairs that is becoming more and more popular in orthopedic surgery, right? Foot and ankle surgeries. We're seeing it a ton with Tommy Johns at the elbow. We're starting to see it with, more knees with MCLs, that sort of thing. And, interesting, with this knee with an MCL, we have loss of range of motion at both ends of the spectrum, both flexion and extension, which kind of interesting. But why don't we start with this? Does anybody have one of these? Has anybody seen one of these here? This is just kind of more, speculative here. We see a ton of these in other joints, but not so much the knees, I would say. So what do you guys think? Who wants to start tackling this in terms of obviously they're looking for advice here. What do you think? Dave, you want to start?
Yeah, it kind of works out where the next series of questions in the journal club maybe later we have, but I just seem to have a lot of post-op knees right now. I just have an influx of ACL tibial plateau fracture. And I was talking to Lenny about this because 2 of my people are ACL or tibial plateau. They also have MCL sprains, and they all just tend to really struggle right now with quads. So they kind of have a similar situation, which is all their flexion restrictions are medial joint pain because of the MCL. Their quad is struggling a bit on a straight leg raise, and they're struggling with flexion range of motion as well. And I feel like we talk a lot about the research on okay, AMI can do icing and this kind of stuff to get the quad going, but that also maybe is going to make flexion struggle if you ice the knee for 20 minutes before you try to bend it, right? And then when someone has MCL pain, it's that's the limiting factor. You don't want to crush somebody and make the joint get cranky and angry, but you want to get them going. And so I just feel like when you deal with complex knees that have new surgeries or a lot of things going on, you're playing this tug of war between like what's the most important immediate goal. And I've like leaned on Lenny a bit because it's like, okay, well, the first thing is like we got to get this person's motion and like get them off crutches and get them comfortable. So maybe you prioritize that, and the quad is the next thing to tackle after maybe the motion makes progress, the pain gets down, the swelling is down. That's only going to make strengthening more comfortable because of the AMI, right? Swelling is a big indicator of AMI. So maybe you prioritize the most important next domino and you tackle that for a week or two and just kind of give a little bit in the strength bucket, knowing that maybe long term strength will come a bit more long term and it will be a grind, but it's more important to get the motion going and get the swelling down and not lose that and get a scar tissue situation than have a really strong quad but a really stiff leg that's not functionally useful. So I just want to jump in first because I feel like I'm living through a bit of what Brent is going through with all these tough cases that are just a lot of moving pieces together. You're like, all right, is it the quad? Is it the knee? Is it the pain? Like, what do I tackle first? So yeah, that'd be my suggestion.
Yeah, I mean, I think we would all agree range of motion is got to be, key here. Maybe this is a stupid question. I don't want to go off the rails here with this episode here too, but like, are we over diagnosing or calling things AMI? I mean, can't you just be weak just because it's been 3 months and you don't have full knee extension and you haven't actually had a full quadricep contraction in probably 3+ months? And the only reason why I bring that up is that like are our treatment strategies off sometimes, just because you have 3 months of atrophy versus an actual inhibition? I don't know. What do you guys think?
Yeah, I mean, I'll jump in. Dave talked, like I said, we talk all the time. And, I agree. Like normally you eat ice, right? The recent research is ice and get the quads facilitated. But I think in the situation that he's in Brenna's situation, I would tell them to heat it. Like, let's make the person comfortable. Let's change their, sensory input from a freezing cold, I'm uncomfortable position to let's heat and work on easy motion, multiple bouts of easy motion. So if the person has lost flexion and extension and it's 3 months out, you're either going down a surgical route to clean up scar tissue very soon, or you really need to be aggressive with your home program. And if I know who this person is, we can communicate off the record here, or off, on via phone. But I would say get extension. That's the priority. Long duration type stuff, multiple bouts a day. And then the flexion, you're same thing. Maybe you get a flexionator. Maybe you get them to do something. You have them do stuff at home multiple times a day. But you're not dealing with just native tissue. You're dealing with an internal brace. So now you start to wonder: was it locked in too tight? Is the isometry point where it needs to be? Meaning the brace is going to kind of move with the knee and not stiffen up when you get through certain degrees of motion. Because you see that with the elbow, if they lock it down too much and it's not attached exactly at the isometry point on the joint and fixed at a certain point. And I'm not a surgeon, so flexion extension, if it's at 30 degrees or 50 degrees where they lock it down, I don't know what it is for a knee MCL, but if they don't do it precisely, that internal brace is going to tighten up potentially as you go through certain ranges of motion. It's not going to stay in its normal length position throughout the range of motion. And so you might be dealing with that. And so you got to determine what the end feel is, what gains are you making, how are you making it. And you might be just climbing a wall that you're never going to climb because of the surgical procedure that you may never know is the cause, but that it could be the cause. So, that's when you're communicating with the doctor.
Follow up on that, Len. Would you ever consider long load duration into flexion? Because I have like one with a tricep repair who's just like, it's just an uphill battle to get his thumb out of the groove. I wonder
definitely.
MCL.
I got a Tommy John right now who had an internal brace who he's got dynasplints working on, flexion. For a knee, I'd recommend a flexionator. So you sit in a seat, you crank a device and it slowly bends your knee. You put a hot pack on your knee and you just sit there for 10, 15 minutes. And it's going to slowly get that collagen to maybe stretch out and stay permanently elongated. And that's the key. We're not getting permanent deformation and elongation of the scarring and collagen tissue. And that's what you need. You need a permanent elongation. So the flexionator would be my recommendation. It's a huge device. It's like a folding chair with a big device. You sit in it, you crank. It's got a hydraulic crank, and you literally just sit at end range, position for a period of time, and then you slowly crank a little bit more to get a little more flexion. So you're trying to get that collagen stretched out. It's going to be a challenge, especially 3 months out. But there's hope because it's only 3 months out. So it seems like forever. But if it was, 9 months out, 12 months out and beyond, collagen is tough stretching out that far out after surgery.
When do you start getting nervous? I mean, I'm kind of
Now,
nervous at 3 months.
yeah, now,
Right? I was going to say, like,
that's why I
yeah,
said
okay.
we're either talking surgery now or,
Right.
I don't know. Hopefully, the discussion is beginning to, especially, I don't know what the motion is. If it's 20, lacking 10 or 15, I'm going to guess to maybe 60, 70. I'm going to guess if I don't know this person or what the case is. But that's typically what you see. We maybe get to maybe 90 or 100. But I'll bet it may not even be that. You get an uphill battle.
So, I mean, you can go back and listen to a bunch of episodes and stuff and hear how we deal with stiffness post-operative, right? Let's switch gears here, a smidge here about, theoretically here, the internal brace concept here. Let's assume, right, just for the sake of answering this question, that this is an over-constrained joint surgically, right? And it's being over-constrained by the augmentation to the repair that is designed to create stability in the injury. It's 12 weeks. You don't have range of motion in both directions.
Yeah.
How hard do you push?
It depends. I would want to make sure that they had an x-ray, that they don't have any kind of heterostopic ossification, because that can happen. We see that in the elbow. It might be a little different with the knee than an elbow. But I'm not killing them, but we need to be somewhat aggressive. But I think the multiple bouts of easier motion throughout the day is going to be your key, so you're not really aggravating the tissue. You know what I mean? That's the key. They can come to PT with me for an hour or whatever, but they need literally the other 16 hours that they're awake. They are trying to do something.
Yeah, makes sense.
That's going to be the key.
I almost always say that to people. Like, if you're that stiff, I think your number one thing is always just like, you need to be doing more range of motion throughout the day, like hourly type thing. But Dan, what do you think?
Yeah, just one more thing, and I believe I learned from you guys, is that I think you can kind of tell how folks are doing from session to session, day to day, and that can dictate a little bit how hard you push.
Yeah.
I think one of the issues, if you push too hard, sometimes they go backwards, right? They lose range of motion, gets too painful, too sore. So I think we're usually proponents of, let's do a lot of frequent motion throughout the course of the day. I'll tell people every hour, do range of motion, right? We'll see if they're making progress. And I might be a little more aggressive and see how they respond to it. So I try maybe a little more aggressive range of motion, joint moves, whatever it is, right? If it's not a knee, somewhere else, and see how they behave, see how it goes next session, see how their pain levels are, see how their function is. So if things are progressing and we're being more aggressive, I think that's good. But if you're being more aggressive and they're getting worse, I think that's probably a bad thing. But that's probably one of the ways I would go about figuring out how hard to push or how much I have to back off.
These MCLs scar down. Like, this is the issue. This is why pre-surgery, if they have like a grade 1 or grade 2, you calm the knee down and don't jump into an ACL surgery with a grade 1 or grade 2. This is a grade 3 that needed extra, stabilization. They scar down. And I imagine either early on they were too conservative. Maybe the protocol was too conservative, or there was a lot of pain and the person was fearful. So who knows what the personality is of the person receiving this treatment from Brenna. And at this point, they're probably beat down mentally from everything, and probably very fearful to get their knee moving. So you're dealing with that too. So you got to play that game and make them feel comfortable mentally about it. But the MCL scar down, lateral side knees, I've talked about this in the past, lateral side of stuff, LETs, like we've talked about, Dave, swell up, painful swelling, MCL side, medial side, scar down, pain. Those are the kind of the general principles of the knee joint.
Yeah, pretty common. And I would say, going back to even my own question here a little bit, it's 12 weeks. I mean, I think you have to push, right? So like, I guess there's some fear. Let's assume it's an over-constrained joint, just for the sake of answering this question. What do you do if it's an over-constrained joint surgically? At 12 weeks, I think you got to push. I've had this question about elbows, and I've talked to all the best elbow surgeons around the country, and they say push when this happens. So, something to keep in mind. I mean, I don't think we're 100% sure why these internal braces work. And I think we have a decent understanding, but some people think it's the internal brace that's working. Some people I know just think that the internal brace creates integrity of the repair and keeps that repair tissue together longer. So that way, maybe you get a better repair over time. Right. So, I think you're not going to function with a range of motion loss, especially with knee extension. You're never going to get quad back if you don't have your knee extension. So if you don't start pushing now, I mean, I think you're at time. When do you really panic? So let's say the doctors, or say they haven't go back. So it's 12 weeks. When do you say, yeah, you got to go back to the doctor? Like, obviously we're gonna start pushing. She just adopted this person. Do you give it a month? Do you give it 2 months? What do you think?
You send them back to the doctor.
Just now,
Usually,
right? Just start the
they'd have a
process.
2 week, a 6 week, and a 12 week follow up. So you're hoping right
Right.
around now they're about to have another follow up. You've inherited the case. You're doing your assessments. You're talking to the person. You're trying to develop a rapport with the person. And I think your professional opinion at this point is, I think we need another look. We need another intervention, or just, well, let's get the doctor's opinion on this. Let's get an X-ray, MRI, or something that's going to give us more information on what's going on in that knee joint to help
Makes
me out,
sense.
so I can push appropriately. Yeah.
Yeah, that makes sense. I got to say, with these internal braces, the doctors are loving them, right? They're excited about them. As a rehab person in the background, they're different, right? They feel different, they act
Yeah.
different. They're different. So this is something new, right? We've been doing this for a really long time. And the experiences that we're having with these patients post-operatively are different. I'm not saying good or bad. They're just different, right? So I think, we need to learn to push a little bit. I was very nervous with the Tommy Johns with these to push, right? But then I talked to all the docs and they're just like, push, right? Or otherwise you're going to lose that motion over time. So, they have confidence in the integrity of these repairs. So that made me feel a little bit better. But, usually with just like a reconstruction, you don't have, it's a different pliability to the tissue, I guess. So, this is a completely different feel for us. So we're all learning, Brenna, like we're all going through this together. I think we're going to have some that get too tight, just like we have, right, with the other joints, and you're going to have some that go perfect, until we just kind of find that happy ground. So, anyway, good question, Brenna. Thanks for submitting. If you have a question like that, head to mikereinold.com, click on that podcast link, and be sure to subscribe to the podcast so you can get updates on our future episodes. Thanks so much.